the cutting balloon. A cutting balloon is a bulky device. However, it changed the use of PTCA. When it came out, stents were not widely used in the late 80s and in the first 90s. And this type of device was able to crack the lesion. However, there was a rate of complication which was a little bit high for that time, and the risk of perforation was there. So if we want to have a modern generation scoring balloon, we have to understand how to use it, and we have to take all of the opportunities that this device, like the Wedge, is able to bring us. It is very important to correctly size the balloon. We may size via the angiography. If we have intravascular imaging, it is probably better, but we know that we cannot use intravascular imaging for all of our cases. So we may also use the angiography. And we should try to keep the balloon to artery ratio between 1:1, or maybe a little bit, a quarter or measure smaller for the scoring balloon. This for sizing. The inflation in our practice, especially in native vessel disease, should be done slowly. So we have to take our time to inflate the balloon. Obviously, if the patient is able to resist to the pain, obviously, otherwise we have to go faster. And then we have to reach the nominal. With the wedge, we also have the possibility to have a non-compliant wedge scoring balloon. So in this case, we may reach also higher atmospheres. In some cases, also with the newer generation scoring balloons, it can be difficult to deliver the device to the lesion. So we may use the Leopard crawl technique, which means that we go the more distal we can with the scoring balloon, then we inflate it slowly at 1 to 2 atmospheres. So then we deflate, we keep pushing it, and sometimes it is this technique is helpful to advance a little bit the balloon, and then we go on. But these are some tips and tricks that we use for the complex cases. As I mentioned earlier, we had the cutting balloon, which helped us in obtaining an immediate higher success, obtaining a larger final MLD. However, as I mentioned before, we had a higher risk of complications, mostly perforation. We have also one study from Laura Mauri, who showed clearly how cutting balloon was not able to lower binary stenosis. And we all know that with the blades of the flex dome, it is very difficult to deliver the balloon to the complex lesions. Now we have the wedge, which has a much higher deliverability and trackability as compared to other scoring balloons. Thanks to the design, we have a very performant balloon, and this performant balloon has an external nitinol wire which is able to crack the lesion easier. As I said, we have a non-compliant or a semi-compliant balloon, which we may decide to use. We may also decide to use a kissing balloon with 2 wedge balloons in case we use a 6 French. 6 French is the guiding catheter that we use every day. We don't use a 5 French, so we may do a kissing balloon with 2 wedge. This is something that we cannot do with other scoring balloons.